questions about your genes or your DNA. Let's find the answers. Ask a genetic counselor.
Hey, everybody! Welcome to the first episode of the podcast, Ask a Genetic Counselor. I'm your host, licensed genetic counselor Sam Geere. I'm so glad you're here, whether you're a patient, provider, a student, or family member, or simply just curious, you're all welcome. And on this podcast, I'm going to answer questions from you every other week. So feel free to leave any questions you want me to address in the comment section of these podcasts. There's no questions that's off limits. So, say you're scared to ask something, you can always create an anonymous YouTube account and ask it that way. And I'll get through as many of your questions as I can. Now, I do want to say that the questions answered here for educational purposes only, so they should not be considered medical advice. I can't provide personalized medical recommendations or interpret individual genetic test results, as this isn't a clinical consultation. Now, without further ado, let's jump into our questions for today. Question 1 says, Hello. Are there any early tests that parents can take before marriage or before pregnancy to make sure they are not carriers of a disease causing gene? This is such a great first question because it gets at something that many people don't realize exists. First, the short answer is yes. There are absolutely genetic tests that can be done before pregnancy or even years before pregnancy to learn whether someone is a carrier for certain genetic conditions. Now, before we talk about testing, let's make sure we're all on the same page about what a carrier actually is. And actually, before we even define a carrier, I want to take one step further back because I realize not everyone listening has a genetics background. So, one thing that surprises a lot of people is that we generally have two copies of most of our genes. And you can think of genes as instruction manuals that tell our bodies how to grow, develop, and function. For most genes, we inherit one copy from the egg and one copy from the sperm. So essentially, we have two versions of the same instruction manual sitting side by side. Now, sometimes one of those copies contains a change. Genetic counselors often call these variants. Most variants are completely harmless. In fact, differences in our DNA are part of what makes each of us unique. But occasionally, a variant can affect how well a gene works. And that's where the term carrier comes in. Because when people hear the word carrier, they sometimes imagine someone carrying around a disease that might suddenly appear at any moment. But that's not really what we're talking about. A carrier is someone who has one working copy of a gene and one copy that doesn't work as expected. For many genetic conditions, having one working copy is enough for the body to do its job normally. And that brings us to another term you may have heard of before: recessive. A recessive condition generally occurs when both copies of a gene aren't working properly. So if someone has one working copy and one non working copy, they're typically considered a carrier. If someone inherits two non working copies, one from each biological parent, that's when they may develop the condition. And this is why carrier screening often looks at both reproductive partners. We're trying to understand whether they happen to carry changes in the same gene. For many recessive conditions, carriers are completely healthy. They usually have no symptoms. They never know they're carriers unless they have genetic testing. And this is where things get interesting. Every single person listening to this podcast is likely a carrier for multiple recessive genetic conditions. Every single one of us, including myself. So if you've ever wondered, am I a carrier? The answer is probably yes. The question is, a carrier for what? Now, let's use cystic fibrosis as an example because it's one many people have heard of. Imagine you have two copies of a gene. One copy came from the egg, and one copy from the sperm. So let's go back to our two copy example. If one copy has a disease causing variant and the other copy is working normally, you're typically a carrier. Because you still have that working copy, your body can often make enough of the protein that it needs. You don't have cystic fibrosis, but you can pass that variant on to future children. The situation becomes important when both reproductive partners happen to be carriers for the same condition. Because if both are carriers, there can be a chance for a child to inherit two non working copies, and that's when the child may be affected. Now, this brings us back to the original question: how do we figure out if someone is a carrier? The most common option today is something called expanded carrier screening. Expanded carrier screening looks at many genes at once, sometimes dozens, sometimes hundreds. Depending on the laboratory, it can be even more than that. And one of the things I really like about expanded carrier screening is that it doesn't depend heavily on family history. Historically, carrier screening was often based on ancestry. For example, someone may be offered screening for Tay Sachs disease because of their ancestry. But as populations have become more diverse and people have mixed backgrounds, ancestry based screening can miss carriers. Expanded carrier screening allows us to look more broadly. Now, I do want to mention something important. While genetic testing can provide information that a person has a reduced risk, it does not entirely eliminate risk. And this is something genetic counselors spend a lot of time discussing. Sometimes people think, oh, good, my carrier screen was negative. This means that there's a zero chance of a genetic condition. Unfortunately, genetics isn't quite that simple. The testing has limitations, there are conditions that aren't included, there are variants that may not be detectable yet, and there are many genetic conditions that aren't recessive at all. So a negative carrier screen is reassuring, but it isn't a guarantee. And I think that's one of the biggest themes in genetics. We often work in probabilities and risk reduction rather than guarantees. Another questions I sometimes hear is, should everyone have carrier screening? And honestly, that's a personal decision. Some people want as much information as possible before a pregnancy, others don't. Some people feel that knowing this information helps them prepare, others feel differently. And one core principle of genetic counseling is respecting that people have different values. Our job isn't to tell somebody what they should do, our job is to help them understand their options. So, yes, testing exists. Expanded carrier screening is commonly available, and it can be done before pregnancy, during pregnancy, or sometimes as part of fertility care. Now, let's take a look at question 2. Question 2 states, how can Jacob's syndrome happen if a male is supposed to have XY chromosomes and a female is supposed to have XX chromosomes? This is another really good question because I think most of us learned in school that people assigned male at birth have XY chromosomes and people assigned female at birth have XX chromosomes. And while that's often true, biology is sometimes more complicated than the simplified version we're taught. So let's talk about Jacob's syndrome. Jacob's syndrome is also called 47XYY syndrome, and the name tells us exactly what's happening. Most individuals assigned male at birth have one X chromosome and one Y chromosome. However, individuals with XYY syndrome have one X chromosome and two Y chromosomes. So naturally, people ask, where did the extra Y come from? The answer usually comes down to a process called non disjunction. Now, I know that sounds like a pretty scary word, but the concept itself is actually pretty simple. When sperm and egg cells are being made, chromosomes are supposed to separate. Think of it like dealing cards. Each card is supposed to go into the correct pile, and most of the time that happens perfectly. But sometimes it doesn't. Occasionally, two chromosomes travel together when they were supposed to separate. When that happens, one reproductive cell can end up with an extra chromosome. If a sperm carrying an extra Y chromosome contributes to a pregnancy, the resulting chromosome pattern can be XYY. And one thing I really want to emphasize here is that nothing causes this intentionally. Parents don't do anything wrong. This isn't caused by something someone ate. It's not caused by stress. It's not caused by exercise. It's usually just a chance event that occurred when reproductive cells were forming. And honestly, that's one of the hardest things for individuals to grasp sometimes. People naturally want a reason. They want to know what happened and they want to have an answer so there's a way to control the situation. And sometimes the answer is simply that biology isn't perfect. Now, let's talk a little bit about what XYY syndrome actually means, because many people have outdated information about this condition. Years ago, there were some misconceptions suggesting that individuals with XYY syndrome were more aggressive or more likely to engage in criminal behavior. Those claims have largely been discredited. And they're a good reminder that genetics research needs to be interpreted carefully and is constantly evolving. Today, we know that many individuals with XYY syndrome live healthy lives and may never even know they have an extra chromosome. Others may experience things like taller stature, learning differences, speech delays, and developmental differences. But there is a huge amount of variability. And that's something you'll hear me say over and over on this podcast. Genetics loves variability. Two people with the same diagnosis can have very different experiences. That's true for chromosome conditions, single gene conditions, and it's true for many aspects of health. One thing I think is helpful to remember is that chromosomes are instructions. Having an extra chromosome doesn't necessarily mean something dramatic is going to happen. Sometimes it does, and sometimes it doesn't. It depends on which chromosome is involved and how the body chooses to respond. And that's one reason why genetic counseling can be so important. When someone hears a chromosome result, the diagnosis itself is only part of the story. The other part is understanding what the diagnosis might mean for that specific individual. Now let's move on to question 3. Question 3 states, can you be a carrier for a genetic condition and never know it? Absolutely. In fact, this is probably the norm rather than the exception. Remember when we talked earlier about carriers? Most carriers have no symptoms at all. That's why carrier screening exists. Because without testing, most people would never know. And I think this surprises people. Sometimes someone comes into a genetic counseling appointment and says, no one in my family has a genetic condition. And that's often true. But it doesn't necessarily mean there aren't disease causing variants being passed down through generations. So imagine this, a family passing down a recessive variant for 10 generations. If nobody happened to have a child with another carrier, the condition may never appear. The variant is still there though. Nobody knew it, nobody did anything wrong, it was just simply hidden. And that's one of the reasons genetics can feel so fascinating. Sometimes information has been quietly moving through a family tree for centuries, not causing symptoms, not drawing attention, just being passed from generation to generation silently. Then suddenly, someone undergoes carrier screening and discovers it. I think one of the biggest misconceptions people have is that family history always tells us everything. While family history is incredibly valuable, it's not perfect. Families are small, information gets lost, diagnoses change, people may not know why a relative died, adoptions happen, donor conception happens, families lose touch. There are a lot of reasons why information may be incomplete. So that's why we often combine family history with genetic testing. Neither one tells the whole story by itself, but together they can provide a more complete picture. And if you're listening and wondering whether you might be a carrier, you're asking exactly the kind of question carrier screening was designed to help answer. Not because everybody needs testing and not because everyone should make the same choices, but because information can help people make decisions that align with their own values. And ultimately, that's what genetic testing and genetic counseling are all about. All right, moving on to our next question. Question 4 says, if genetic conditions run in families, why is someone sometimes the first person in their family diagnosed? This is one of my favorite questions because it gets at something that confuses a lot of people. And honestly, it makes sense that it's confusing. We hear phrases like it runs in the family all the time. So then someone gets diagnosed with genetic condition and says, wait a second, nobody else in my family has this. How can it be genetic? And there are actually several possible explanations for this. The first is that a condition may have been in the family, but nobody knew it. Maybe relatives had mild symptoms, or maybe they were misdiagnosed. Maybe they never sought medical care for their symptoms. Or maybe medical genetics simply wasn't available when previous generations were alive. And that's something I think we forget sometimes. Genetic testing as we know it is actually pretty new. There are people listening to this podcast who were born before DNA was even discovered. So when we look back through a family tree, we aren't always comparing apples to apples. Sometimes the information simply wasn't available. Now, another possibility is something called a de novo variant. Now, de novo is just a fancy Latin phrase that means new. A de novo variant is a genetic change that occurs for the first time in an individual. So, in other words, it wasn't inherited from either parent. It happens spontaneously during egg or sperm formation or very early in a person's development. And before anyone panics, I want to emphasize something. This is a completely normal part of biology. Every single person listening to this podcast has genetic variants that weren't present in their parents. All of us. And most of them don't matter. Now, occasionally one happens in an important gene, and when that occurs, it can result in a genetic condition. So, yes, someone can absolutely be the first person in a family diagnosed with a genetic condition. And that doesn't make the condition any less genetic. It just means that the genetic change originated with them. One of the things I often tell patients is that genetic and inherited are not always the same thing. All inherited conditions are genetic, but not all genetic conditions are inherited. That's a distinction worth remembering. Now let's take a look at question 5. It asks, what is the difference between a screening test and a diagnostic test? This is a great question because understanding this difference can prevent a lot of confusion and anxiety. In genetics, we often talk about screening tests and diagnostic tests. And honestly, the names themselves tell us a lot. A screening test screens, a diagnostic test diagnoses. But let's unpack that. A screening test estimates risk. It's asking, based on the information we have, how likely is this condition? Now, a diagnostic test asks, is the condition actually present? So let's look at a non genetics example. Imagine you're at the airport. The metal detector is a screening tool. It identifies people who may need further evaluation. It doesn't automatically prove that someone has something prohibited. It's the follow up search that's more diagnostic. Genetics works similarly. Take cell free DNA screening during pregnancy, for example. This is one of the most common prenatal screening tests. A result might suggest an increased chance for Down syndrome, but the screening test alone does not diagnose Down syndrome. Instead, it identifies pregnancies that may benefit from further evaluation. That's why diagnostic tests like chorionic villus sampling or amniocentesis exist. Those tests can directly analyze fetal genetic material, whether it be from the placental tissue or from the fetus itself. Now, one thing I think is important is that people sometimes hear screen positive and assume a diagnosis has been made, and that's not necessarily true. This is one reason genetic counseling after screening results can be so helpful. It's easy to hear result and immediately jump to the worst case scenario. But the meaning of a screening result often depends on many factors, including age, background risk, test performance, and follow up testing. So, whenever you hear the word screening, think this is estimating risk. And whenever you hear the word diagnostic, think this is trying to determine whether the condition is actually present. Now, question 6. It asks, if I have a genetic condition, will my children definitely inherit it? The answer is, it depends. And I know that sounds like the most genetic counselor answer ever, but it's true. Inheritance depends on the specific condition and how it's passed through families. For example, some conditions are inherited in autosomal dominant matter, and in those situations, someone may have a 50% chance of passing the condition on in each pregnancy. Notice I said 50%, not 100%, not guaranteed. 50%. And I think probability is one of the hardest concepts for us to grasp because our brains naturally want certainty. I mean, I know mine certainly does, but genetics often doesn't work that way. Every pregnancy is its own event. So think of what it's like when you flip a coin. Getting heads 5 times doesn't influence the sixth flip. Similarly, previous pregnancies don't change the probability for future pregnancies. Other conditions are inherited in autosomal recessive ways. Others may be X linked. Some conditions result from de novo variants and may have very different recurrence risks. This is one of the reasons genetic counselors spend so much time talking about inheritance patterns, because understanding how a condition occurred often helps us estimate future chances. And I want to emphasize something else. When people hear recurrence risk, they sometimes feel like they're being told what decision they should make. That's not what genetic counseling is about. Our role is to provide information, and how someone uses that information is deeply personal. Different people make different reproductive decisions based on the same information, and that's okay. There isn't one correct response to genetic risk. There are many reasonable responses depending on a person's values, beliefs, experiences, goals, and circumstances. That's one of the things I love most about genetic counseling. It's not about telling people what to do, it's about helping them make informed decisions that feel right for them. Question 7. Why do genetic counselors ask so many questions about family history? Now, I promise we're not being nosy, though I know it probably feels that way sometimes. People come in expecting to talk about themselves, and then we're suddenly asking about grandparents, cousins, aunts, uncles, half siblings, great grandparents, and family members they've never even met. And they're thinking, why are we talking about my second cousin when I'm the one sitting here? The reason is that family history can reveal patterns, and genetics is often about patterns. Sometimes one person having cancer isn't unusual, but three relatives with the same cancer at young ages, that starts to tell a story. Sometimes one person with developmental differences isn't enough information, but several relatives across generations, that can provide important clues. Family history is one of the oldest genetic tests we have. In many ways, it was the original genetic test. Long before DNA sequencing existed, clinicians were using family trees to identify inheritance patterns. Now, family history isn't perfect, and I know we touched on this earlier. Again, it's because people may not know details. Families might be small, records could be unavailable, but when family history is available, it can be incredibly powerful. It's one piece of the puzzle. And genetics is often about putting lots of puzzle pieces together: family history, medical history, genetic testing, physical findings, laboratory results. Every piece adds information, and together they help us better understand what's going on. Let's move to question 8. Question 8 asks, can genetic testing tell me every disease I'll get in the future? This is one of those questions where I completely understand why people ask it. If you've ever seen a news article about genetics, the headlines sometimes make it sound like we're just one test away from knowing someone's entire future. Like, we'll swab someone's cheek, send off a sample, and then get back a report that says, here's every disease you'll ever get, exactly when you're going to get it, and how severe it'll be. But genetics doesn't work that way, at least not right now. In reality, genetic testing is incredibly powerful, but it also has limitations. And understanding those limitations is really important. Let's start with something that might surprise people. Not all diseases are genetic. Or maybe a better way to say it is that not all diseases are primarily genetic. Many health conditions are influenced by a combination of genetics, environment, lifestyle, chance, aging, and things we don't fully understand yet. Take something like type 2 diabetes. There are genetic factors that can influence risk, but genetics isn't the whole story. The same thing is true for heart disease, many cancers, many mental health conditions, and this is because human health is complicated, and our genes are only one piece of that puzzle. Now, there are some conditions where genetic testing can be extremely predictive. For example, if someone has Huntington's disease, or certain hereditary cancer syndromes, or inherited cardiac conditions. In those situations, genetic testing can provide very meaningful information. But even then, there still can be variability. One person may develop symptoms earlier, another person later. One person may have a more severe presentation, another may have a milder one. So, even when we identify a genetic cause, there can still be uncertainty. And I know uncertainty isn't always comfortable. Humans tend to like certainty. We like yes or no answers, guarantees. But genetics often operates in shades of probability rather than certainty. One thing I tell patients is that genetic testing is often better at answering certain questions than it is at predicting the future. For example, do I carry a particular genetic variant? That's often a question genetic testing can answer very well. But will I definitely develop this disease? That may be a much harder question. And I think that's important to remember when we see advertisements for direct to consumer genetic testing. Sometimes the market can make genetics seem more predictive than it actually is. Your DNA matters, absolutely, but your DNA is not your destiny. And I think that's one of the biggest takeaways from this question. All right, question 9. It asks, why are some genetic conditions more common in certain populations? This is another important one, and it's also a question that requires some nuance. Because when we talk about genetics and populations, we want to be careful, respectful, and scientifically accurate. One reason certain genetic conditions are more common in some populations is something called a founder effect. Now, founder effect can sound complicated, but the idea is actually pretty simple. Imagine a small group of people starts a community. If one or more members of that group happen to carry a particular genetic variant, that variant may become more common in future generations of that population. Not because there's anything unusual about the population, not because anyone did anything wrong, simply because the genetic variation that happened to be present when the population was established is continuing to be passed down within this small group. And we see this in many populations around the world. One example many people have heard of is Tay Sachs disease in individuals of Ashkenazi Jewish ancestry, but there are many other examples. And one thing I want to emphasize is that every population has genetic conditions that may be more common within that group. This isn't unique to any one ancestry. It's part of human history, human migration, human population growth, and just human genetics. Now, another thing that's important is that ancestry and genetics are not the same thing. People often ask, I'm part this and part that. What does that mean for my risks? And honestly, it can get complicated. Again, people have complex family histories, mixed ancestries, adoptions, unknown family information, and that's one reason why expanded carrier screening has become so popular. Instead of making assumptions based on ancestry, expanded carrier screening looks directly at many genes. And I think that's generally a good thing because it helps us move away from assumptions and toward individualized information. One thing you'll probably hear genetic counselors say a lot is risks can vary between populations, but every person is an individual. And that's really the key message here. Population data can be helpful, but it doesn't tell us everything about a specific person. And now for our last question. Question 10. What exactly does a genetic counselor do? I thought this would be a fun question to end on because there's a decent chance some people listening don't actually know. And honestly, that's okay. I had no idea what a genetic counselor was until I stumbled across the profession myself doing some job searches. So if you're listening and wondering, wait, what exactly is your job? You're not alone. A lot of people think genetic counselors only explain genetic test results. And while that's certainly part of the job, it's only one piece. At its core, genetic counseling is about helping people understand and adapt to genetic information. So that can happen in a lot of different settings. Some genetic counselors work in prenatal genetics, some work in cancer genetics, some work in pediatrics, while others may work in cardiology, neurology, the list goes on. And a typical appointment might involve reviewing family history, discussing medical history, talking about genetic testing options, explaining results, and discussing risks and limitations. Also, it could involve helping someone understand what the information may mean for themselves or for their family. But there's another piece of the profession that I think sometimes gets overlooked, and that's the counseling part of it. Because genetics is rarely just about science, it's often about emotions. It's about uncertainty. It's about decision making and family dynamics. It's about hopes and fears and expectations. And sometimes people are surprised by how much of genetic counseling appointments involve talking through those things. Another thing I love about this profession is that it sits at that intersection of science and the humanity of someone and their experience. While we're talking about DNA, we're also talking about people. And those two things can't really be separated. Another thing I want people to know is that genetic counselors aren't here to tell you what to do or what choices to make. This is a core value of our profession. We know that different people have different beliefs, different goals, different experiences, and different values. Our role is not to make decisions for people. Our role is to provide information, support, and guidance so people can make the most informed decisions for themselves that align with their values. And honestly, that's one of the reasons I fell in love with this field. Every patient is different, every family is different, and every story is different. And even though genetics provides the science, It's really the people that make this work meaningful. And this brings us to the end of our very first episode of Ask a Genetic Counselor. Thank you so much for spending a part of your day with me. If you enjoyed this episode, be sure to leave your comments or questions in the comment section below. And remember, there's no question that's off limits. Whether you're a patient, a student, a healthcare provider, family member, or someone just curious about genetics, I would love to hear from you. And if you're nervous about asking publicly, you can always create an anonymous account and ask that way. Thank you again for being here. And until next time, keep asking questions, keep staying curious, and I'll see you in the next episode of Ask a Genetic Counselor.
Got questions about your genes or your DNA? Let's find the answers. Ask a genetic counselor.